I want to start by just saying this. We have a steering committee that helps to plan this event, and they work really hard. They conceive the program, they plan the sessions, and so before we begin, I kind of like to invite the steering committee members to stand up and just be acknowledged. So they are Karen Adelson, she's in the class of 2022, Razi Ali, class of 2023, Catherine Anderson, 2021. I have Catherine's here. Barbara Barnett, 2013. Yay! Chris Blasky, 2014. Peter Curran, 2013. Robert Eubanks, 2019. Robert. Dale Holly, 2023. Hope Plavin, 2016. Yay! Mark Whitty, 2020. And Courtney Woodward, 2023. Yeah. So, yeah, thank you all. It takes really a lot of people to put this together, and the other big, huge thank you I want to put out is to Kelly Barton, who handled all the logistics and orchestrated the event. And I don't think she's in here to hear it, but anyway, you all met her on the way in, so thank you, Kelly. And then the audience, of course. It's great to see this room so full. I'm relieved, and you know, it's noteworthy because our theme is like workforce shortages, so I think that means that kind of by definition, you're all really overextended and maybe don't even quite have time to be here. And I'm sort of humbled that you took the time away from your stressful work environments to be here. And given the opportunity cost, we're going to try really hard to deliver and make this a valuable day and a half for you. You know, Tim Foster yesterday sent an email to the team planning this session, and it's sort of outlining the compounding challenges that are facing healthcare, and it's really daunting. And so one of the things that I think is a goal for this is to just have the sense that we're in it together and get the support of the community. It helps. It helps. We're social beings, right? And I think that having the feeling that there are other people struggling with the same challenges can be empowering. And then the other thing is that we wanted to try to make this an optimistic, realistically optimistic program. And we're going to hope that you go home with at least one, thing that you can apply in your organization. Maybe more. That would be great, but at least one. And we'll try to focus on the positive and send you home with something that you can use so that life, it'll make a difference and life will be a little bit better. That's the end of my welcome remarks. I want to just touch on a few logistics. So we are videotaping most of the sessions, and you'll get a link to the videotape after the conference. Along with that link will come a link to a survey. We'd love your feedback on the program, and then a link to the survey that you have to complete if you'd like to apply for continuing education credits. You have to complete the CE survey within, I think, 2 weeks, so it's like the end of May, like Friday, May 5th or something. These are our continuing education disclosures, and there is also information in the registration table if you have questions about continuing education. We're going to have Q&A questions after most of the sessions, and so I was going to say there are standing mics on the sides, but we'll have mics for you to ask questions. If you'd like to ask questions during the Q&A, please, if you're an MHCDS alum, just state your name. Either way, state your name, and if you're an MHCDS student or alum, just let us know what class you're in. There's a charging station in that corner if you need to charge your devices, and the restrooms are outside and to the left. Pardon me? Kelly, yes, thank you, Kelly. Yay. Thank you so much. So with that, I'm going to introduce Courtney Woodward. She's going to kick us off. Yeah.
Oh, I need that envelope.
That's yours.
Thank you, Molly. Let's see. Good morning, everyone. And welcome to this year's Dartmouth Symposium, Call to Action, Reimagining How Healthcare is Delivered. Compounding variables such as our aging population, increased burnout, retention rates, growing gaps in healthcare disparities, and underserved communities have all contributed to our current workforce challenges. While many of these challenges were present prior to COVID, the pandemic has further exacerbated them. Within the next 10 years, the AAMC projects that physician demand will grow faster than supply, with population growth and an aging population being the biggest drivers for demand. Burnout has become an epidemic. In a recent study by the AMA, 63% of physicians reported signs of burnout at least once per week, with women physicians having higher rates of burnout than their male counterparts, and that gap is growing wider. In a study done by the ANA, 43% of nurses said they felt burnt out, and only 20% indicated they felt valued within their current work environment. The demand for mental health services continues to increase, yet nearly half of the US population is living in a workforce shortage area. And while there's increased awareness being paid to health inequities, the deficit of equal representation among the industry and the role it plays in increasing disparities cannot go unnoticed. All of us in the room understand the scope and complexity of all of these problems, as it impacts all of us in different and similar ways. The intent of this year's symposium, though, is a call for action for us to come together to start to discuss the undiscussable, to determine how we can collectively best shape the delivery of care going forward, knowing the magnitude of these challenges. So in our time together, we will collectively examine what has worked, what has not, and what still needs to be done. Throughout the next day and a half, we will explore the following. First, we'll start by looking at innovative models and methods across the continuum that were designed to confront workforce challenges within specific disciplines. Second, examine ways to prioritize mental health within our delivery system among escalating needs and a diminishing workforce. Third, acknowledge and take a closer look at our institutions and communities to see the impact that structural racism has among both our existing as well as future workforce. Fourth, determine how we may address social factors that can influence a patient's health while not overburdening an already stressed delivery system. And finally, provide the ability to discuss how technology may be an aid as we think about redesigning our models. So this is a collective journey as we respond to this call to action. And as Molly has already indicated, really want to thank all of you for taking the time out to come here and working together as we start these conversations. This year's symposium would not be possible, though, without the support of Dartmouth, MHCDS staff, and all of our presenters. So we want to give a very special thank you to all of our distinguished guest speakers, panelists, and most notably, our keynote speaker this evening, Michael Dowling, President and CEO of Northwell Health. Thank you all for joining us on this journey. Without further ado, I'm going to turn it over to Dr. Chris Blasky to officially kick off the first session. Chris graduated in 2014 from the MHCDS program. She is a pulmonologist and intensivist at Mass General Brigham Salem Hospital. She was also the president of the medical staff from 2018 to 2020.
Great.
All right. All right. Thank you to the great class of 2014, of whom I think there are two here. Okay. So I am the poster child. George knows I am the poster child. So I am probably the poster child for burnout, front lines, clinical medicine. I'm a pulmonologist and intensivist. I work in a community hospital. We have a 20-bed ICU that tripled in size during the pandemic. Nothing unique, right? This is what we all lived and breathed, hopefully, during it. The reason I'm showing this slide is So this may remind you of Dr. Strangelove. However, the person on the left is Karina Phillip from the great class of 2016. So she cannot be here today, but she and I are both intensivists at Salem. So we're writing the oxygen tanks because we were in a state at that point where the hospital's oxygen system could not provide enough oxygen pressure to run all of our ventilators. So we had to bring in extra oxygen tanks. So that was just kind of an on-the-line thing. However, I'm not really here to say, oh, woe are we. But what we really need to sort out, and if we can go to the next slide, to the slide people, is to take a look at this. So this is on the wall of our intensive care unit. And this is not to be too mystic, although Molly and I talked about this. I don't want to be too mystic about this. But this is kind of a representation of the staff and patients with COVID that we treated for the first year of the pandemic. So we like to look at it as, the trunk and the branches are everybody in the hospital, in the healthcare system, who is holding this stuff together. And the leaves represent the patient. So as you can see, there are some leaves still on the tree. The leaves in gold are the patients that were lost. So this is an idea for us, or just to get the non-clinicians in the room, sort of the magnitude of what the people on the front line have been dealing with. And that's really all I want to say up front, We have great panelists. I would like to now move along, and I would like to introduce Dr. Joanne Conroy. She has led Dartmouth Health as CEO and president since 2017. Dartmouth Health is the only academic health system in New Hampshire, and it's the state's largest private employer. Among her many awards and recognitions, Dr. Conroy was ranked number 18 on Modern Healthcare Magazine's list of the 100 most influential people in healthcare. Dr. Conroy.
Well, thank you. Is picking up, great. Wonderful to be here. And, healthcare is kind of a rough business right now. All of you that are really working in the front lines or the administrative component of healthcare can appreciate that. I'm not sure if we think about what our concerns were in 2017 and what they are now. We could really make any reasonable connection to what kept us up at night then and what keeps us up at night now. But certainly the topic of today is incredibly relevant because it's almost all about workforce. All right. I seem to be unable to advance. Let me see. Oh, great. So it's interesting. I wish we maybe had this conversation, 2 or 3 years ago, when we were throwing the flag on the field that we were having a workforce shortage. We knew that our pipeline for nursing was actually pretty weak, and we had appreciated for many years that this was kind of a crisis that we were going to have to address at some point. However, during the pandemic in 2020, we lost 5 million people out of the workforce. In 2021, we lost another 25. Right now, there are fewer women in the workforce than we've seen in the last 40 years. This is a combination of inadequate childcare. It makes more sense for one of the parents to stay home with children, and often that's one of the female partners in a relationship. There are so many other pressures that actually have restricted women returning to the workforce after the pandemic. The big issue for healthcare is 85% of our workforce is female. And so it affects us disproportionately more than many other aspects of many other industries. And I wish we'd had this conversation probably 2 years ago, that we could say, what would it look like to deliver care if we had 20% fewer people? Because actually that's what we're facing right now. We have to make decisions on how we're going to deliver care differently. And it's not just that we can change the care model and maybe elevate the role of nursing to deliver care in a more supervisory way, and then bring in a bunch of paramedics, LNAs, MAs to actually help create a care team. We don't have those bodies. So the problem becomes much more complicated. So I would say that I like to describe where we are to both people in healthcare and people that are just consumers of healthcare, that we do have really a sketchy patient experience in healthcare right now. And individuals have this slice of their experience interacting with our system. Many of you may say, I can't find a primary care physician. Or you say, it takes me, instead of 30 minutes, it's 8 hours, and sometimes a day and a half to get my prescription filled. Or I'm in the emergency room and I'm waiting for a bed in the facility, and I'm sitting there at our institution for 5 hours, but in many institutions you may be there more than 24 hours. Or my elective procedure, I've had to reschedule that because of inability to access OR time. Every single one of those, and we see them as we lead healthcare systems, is a symptom of not enough workforce. We don't have enough pharmacy techs, we don't have enough nurses, people are closing beds. A third of the post-acute care beds in New Hampshire are closed because of staffing. We don't have enough ED physicians or nurses to process patients quickly. And our perioperative staff is probably close to 50% of the perioperative team in many facilities, and that's OR nurses, that includes techs, and that includes CSR staff, are actually travelers. So that creates a lot of inconsistencies in how you can deliver care in your perioperative space. So it's all about the workforce. Now, let's go to the next slide. How about the next one? So before I talk about solutions, what does it look like when the healthcare system breaks down? As chair-elect of the American Hospital Association, it's interesting, we balance between alarming people and informing people. But let's talk about what it looks like when the health system breaks down. And I think we saw a little of that in COVID. But when you see the entire system struggling with workforce, it's going to feel very foreign to a lot of our patients that, frankly, you can complain about the healthcare system, but usually when you call EMS, they show up in a reasonable period of time. They take you to the hospital. You're not queuing outside in ambulances trying to get into the emergency room. You're escorted into the emergency room, and somebody in a reasonable period of time assesses whether or not what you've come in for is going to kill you. Or if it's something they just have to evaluate more completely and either treat you as an outpatient or an inpatient. But that is part of our healthcare system that I think a lot of people depend on. Our EMTALA rules and regulations basically say we treat everybody regardless of their ability to pay, depending on the urgency of their situation. And healthcare has been able to accommodate that. But if we don't figure out how to do it with fewer people, we will have, and you have heard about situations where ambulances have been delayed in responding to 911 calls at facilities, at homes. You have heard about ambulances that are queued up outside of hospitals. In fact, Yale New Haven has a tent outside their facility to hold patients that are waiting for an inpatient bed. Things that we never thought we would be addressing, we're addressing because of our healthcare workforce shortage. And that's when the system starts to break down, and that's when we start to lose the confidence of the American public. So as leaders in healthcare, we're trying to balance how do we alert people, because many of our elected officials said, we gave you a ton of money during COVID, go away. We really don't want to hear about what you need right now. How do we balance that with appropriately kind of sounding the alarm that if we don't actually do something, many of our systems of care are going to start to break down. At Dartmouth Health, we made a commitment to keep all of our beds open. It costs us a lot of money. That's okay. We're already turning away 500 people every single month for transfers that need care at our facility. We are the safety net for this region. But many facilities, i.e. our nursing homes, but a lot of the for-profit facilities across the country are refusing to spend more than a certain amount on traveling staff. And so they're closing inpatient rooms in order to really manage the cost of that care. That puts us in a pretty precarious position. Next slide. Oops. Actually, go back one slide. Thank you. I have a feeling our animation is creating some problems. So rural healthcare is even a little bit harder. It's kind of hard to recruit up here. You would think people would love to work up here, but I'm telling you that the housing is expensive. If any of you have tried to rent a place at Algeria, like we have a master lease of 150 of those units there, that we're actually subsidizing housing for employees that will move more than 50 miles to come work at Dartmouth Hitchcock. It's interesting the kind of the quality of the housing too. I don't know any of you are from Dartmouth Hitchcock, but if you get on our site where we actually post rental housing, I actually went on it yesterday and found it incredibly depressing. There's a lack of public transportation for a lot of our lower wage workers. You know, we require a car in a lot of rural America. We do subsidize advanced transit. We subsidize Stagecoach. We subsidize the coach that comes up from Claremont. We do everything we can to allow people to live in more affordable communities and actually commute to work at Dartmouth Hitchcock. A lack of childcare. You know, the U.S. has never figured out how to support working mothers. And even though only 20% of our patients require, our employees require childcare, you know, it's still a huge issue. And it's something that I think we've ignored for a long time. Believe me, I've worked in several organizations where you bring up childcare and there's an eye roll across the executive suite that it's a woman thing. It's not a woman thing, it's a workforce thing. And as communities and as a country, we have to address it. We have a widely dispersed population. If you look at our footprint, I mean, it's 4 hours to go from southwestern Vermont Medical Center up to, you know, our most northern facility. And the number of people in that footprint is actually quite small. We are the most rural academic medical center in the country. We have fewer than 170,000 people within 30 miles of Lebanon. And finally, you know, we've got challenges that are created just because of distance for access and poverty. You know, again, transport, the availability of people to actually access care and actually stay connected to their caregivers. Next slide. So what have we done about it? First of all, housing. You know, we have created a fund for developers with other employers in the area. I think it may be up to $6 or $7 million now, so they can actually get low interest loans, so they can actually start housing for low-income workers, not just for Dartmouth Hitchcock, but for the entire community. Again, we support buses, we support ride share, you know, anything we can do to actually get employees to work inexpensively and reliably. Again, childcare solutions, I mean, we are looking at doubling the size of our childcare facilities in order to accommodate the need in the Upper Valley. And I have to say, working with the town of Lebanon, they're building a 200 child facility in Lebanon. Specifically, 51% of that will go to low income wage earners across the area. We're also training childcare workers and offering them employment. We have a partnership with Colby Sawyer. They actually have quadrupled the size of their nursing programs. They're starting an MSW program. We've asked them to kind of think creatively of how we can actually train the workforce for the future as our partner. And they've actually done a great job. They've gone from 40, and the goal is within a year or two to be up to 120 nurse graduates a year. And then we train our own people. We have a Workforce Readiness Institute with a number of programs that go from 9 weeks to 11 months, where we actually pay people to go to school, employ them until they reach their certification, and then offer them employment afterwards. We realize, though, that no one organization, no matter how well organized or funded, can really solve a lot of these problems alone. We have to work with our community partners, absolutely. We have to work with the college, with the larger employers in the area, in every single town and community. If we see somebody that wants to come up forward with a solution, we're willing to talk to them, because this just doesn't affect us, it affects everybody in the area. Next slide. You know what, I think we need to think about how we can replace vacancies with technology, though. We have to. We just will not, people are not going to miraculously appear. And we have an aging population and increasing demands on the healthcare system. We are deploying robots wherever we can. Remember when we would do just-in-time supply chain? Well, frankly, we built our new pavilion so they could store a week's worth of supplies, just because it's cheaper for us to acquire and hold more supplies than it is to try to find somebody to deliver those supplies on a daily basis. So we have to rethink both our infrastructure and how we do our work. I was really excited when Epic sounds like they're going to integrate chatbots into Epic, because, frankly, when we talk about burnout and we talk about, the loss of people to actually document the care, the use of chatbots is going to allow us to interface with the electronic health record, I think, much more easily. And it will help with both with burnout, but efficiency of care. And finally, self-service. We all have call centers. We all have switchboards. We all have hundreds of people that are invisible to a lot of us that are doing something that's really important, but we've got to figure out how do we use technology in order to replace that human effort, and then how do we take those individuals and retrain them for other careers in healthcare. I would say that our future is going to challenge our beliefs about what we could and couldn't do, and also what our communities will accept. I think we make some judgments about the fact that people will not accept a different way of delivering care, but the pandemic showed us that people will accept a lot if we're really clear about why the system of care has actually changed. And I think we're going to all navigate this with transparency, with great communication, and with really engaging everyone across our broader community on what are the innovative ways that we can actually improve how we're delivering care with 20% fewer people. So, thank you.
Thanks so much. And now I'd like to introduce Tim Foster. So Tim is from the MHCDS class of 2015. He is the chair of orthopedics at Newton Wellesley Hospital, part of the MGB system. And he is team physician for Boston College Athletics. In addition to his MD and MS degrees, he holds an MBA from the Sloan School at MIT. Dr. Foster.
That first slide, please. Thank you. So I want to start by telling you two stories. One story is going to have to wait, and that story is about the marathon bombing exactly 10 years ago this week, and this is coming from somebody who was running the marathon turned onto Hereford Street and heard the explosions. But every single person who made it to the hospital in Boston survived. We know that 3 people did not survive, but everybody who made it survived, which is an amazing story unto itself. But my story today that I want to tell you is about Caitlin. Caitlin is a 16-year-old female high school lacrosse player. She's a good lacrosse player. She was playing in a game in which she was being watched by college coaches for Division I when she had a knee injury. That knee injury was a pretty significant injury, and it took her to our pediatric emergency room. By the way, our emergency room was built for 150 patients a day, including our pediatric ER. We're now seeing upwards of 250 patients per day, one of the busiest ERs in the Commonwealth of Massachusetts. So she came to the emergency room, and there was a 5-hour wait. And this is the text that I received from her father on a Sunday morning. And I won't read it to you, but I'll just paraphrase it. Dear Dr. Foster, this is John R. My daughter, Caitlin, is in your emergency room. There are a lot of sick people here. There's a 5-hour wait. He got my cell phone number from another parent whose children I've treated. I think she has written that all over Newton and Wellesley and all over the surrounding community, perhaps in bathrooms, I don't know. But this was my response to her. I'm sorry to hear about your daughter, but please come to our orthopedic-only urgent care center, which is just down the street on Route 9 in Boston. We'll see her. We'll have one of our skilled physician assistants see her. She'll be evaluated. She'll get x-rays. I'll take a look at the films, and then we'll follow up after that. And that's exactly what they did. So this is our orthopedic-only urgent care center. And just a little bit of background here. When you think about musculoskeletal injuries, they comprise 20 to 30% of all ER visits, but many of them are simply not urgent. They're important to the patient, but they're really not emergent. So I started to think about this when I was here in this program, having an orthopedic-only urgent care, and then further solidified when I was at MIT. And when you think about this in general, emergency care is relatively inelastic, right? If you're having chest pain, if you have a tibia fracture, if you have a kidney stone, you're not going to think about negotiating a price or not going to the emergency room. So the demand is relatively inelastic for emergency care. And so when you think about this also, high deductible health plans and co-payments have made that a little bit more elastic, especially for orthopedic care, especially for somebody, for example, like Caitlin, who has a knee injury. So when you think about an orthopedic-only urgent care, and this sounds so simple, right? There was none in the United States when I first started to think about this. So pretty simple idea, but it really creates value, and then the health institution can capture that value as well. So let's take a look at, everybody's probably moaning, right? Oh my God, we're back in class again. But when you think about it's a relatively inelastic demand for emergency room care. This is perfectly inelastic, and that's not truly the case with ER care. But the question is, would you supply the care? Would you be S2 if you could capture the entire episode of care? So think about that for a second. Would you take a lower price point, but you capture the entire episode of care? You capture the MRI scan, you capture the imaging, you capture the surgery, and then you capture the patient's physical therapy. That entire episode of care would be captured. So here are the results. It was a 3-year planning process. I had to convince a lot of people in order to do this. We had a pro forma that suggested that if we saw about 1,000 to 1,100 patients a year, that we would break even. So we have skilled PAs, and they are very skilled PAs, who see the patients. We get imaging on site, and then they're referred to an orthopedic surgeon, for example, like me, and I see them within a couple days, or I'll even call them and go over their imaging by telehealth with them. So the first year, we thought we would be lucky to break even. We saw 5,000 patients. So we have seen 17,000 new patients, and this just started in February of 2021. We've seen 17,000 new patients, and we've seen 20,000 patients because we have a lot of repeat customers as well. There has been no marketing for this. The only marketing for this has been internal marketing to the Mass General Brigham system, meaning we tell our PCPs that if your patients have a problem, send them here, we will take care of them. So we've had people come from all over, and I'll show you a map of where they come from. Here's the best part, our lead time. So Caitlin, our lead time, door to door, 64 minutes. It's a better patient experience, better patient access than the emergency room for patients. It lowers the TME. We're not charging an urgent care fee. We're not charging an ER fee. We're charging an office visit for that patient. So it's better for the healthcare system as well. It really captures value. This has been such a great success for us that Mass General Brigham plans on, the last I've heard, they're planning on opening 9 more around Boston. I think it makes a lot of sense to do that. This is the map. I won't put the numbers to it, but we're this little tiny dot in Norfolk County, just outside Boston. People have come from all over, including southern New Hampshire, Cape Cod. We have a few patients even from upstate New York who've come to this. They find it online, and they come to see us. Patients are sticky, too. So these are new patients in the Mass General Brigham system. Once we get them in the door, they tend to stick with us. So they stick with us for their primary care. They stick with us for their cardiac care. So that's also been really good to see. Our next one is due to open in January 2024 at the Warrior Arena. You probably passed this on the Mass Pike in Boston with the Celtics and Bruins practice facility. That's going to be our next one. I think that's going to be very heavy sports medicine. So back to Caitlin, just to end this story. She was seen in the walk-in clinic. That's what her knee looked like. You don't have to be an orthopedic surgeon to realize there's something not quite right with that knee. And in fact, this is her MRI scan, and her MRI scan revealed that she did, in fact, have an anterior cruciate ligament tear, and she underwent surgery for that tear within a matter of a couple weeks. She rehabbed, she did really well, and she got her Division I scholarship at a school in New Hampshire, an unnamed school in New Hampshire. So when you look at her episode of care, we look at anybody's episode of care, we have counted 68 steps. If you go through the emergency room, we've narrowed that now to 20 steps before you're having surgery, before you're in rehabilitation. So it really has created value for the patients, for the healthcare system, and for the hospital as well. And it's everything that we have learned in this program, right? It's convenience, it's access, it's value, everything that we have learned here. So my last slide, it has been a perfect storm for us. There is certainly an unmet patient demand. We have patients who come and say to us, why don't you advertise this? And the plain fact is, if we advertise this, we couldn't keep up with the demand because the demand is so high. And it gets patients out of the emergency room who really don't need to be in the emergency room. The value proposition has obviously been important for us. I did not plan this around the pandemic. The pandemic, I want to say by serendipity, it's hard for me to say that, but because of the pandemic, people were looking for alternatives other than the emergency room, and this is a great substitute for the emergency room. We had the first mover advantage. Now there's several other places that are starting to do this as well. It's one thing to have an idea, but Chris Trimble would say execution, execution, execution. 10% is the idea, 90% is the execution. And the people who helped me and surrounded me really helped with that. And my last slide, I learned so much by doing this, but this is what I really learned the most. There's nothing you can accomplish if you don't care who gets the credit. So people who are adamantly against this, now it's their idea. And that's great, and that's wonderful. So thank you very much.
Thanks. Can you guys all hear me? We're good. Okay, we're going to start with some questions for the panel, and what we'll do is Courtney and I will alternate, and I'll start with a question for Joanne. We'll also, encourage you guys to follow up the panelists with any questions that you have. So we'll see how many that we can get through. Okay, so first for Joanne, we're all measuring workforce status and the stresses on our employees. And I know that we've all, over the past years, understood a lot more about the needs and the stresses that the individuals that we employ are under, magnified by the pandemic, but they're all there. And you started with your slides by talking a little bit about some of the community-based outreach and non-traditional supports that an employer like Dartmouth Health can provide. So could you talk a little bit more about how can systems, big employers, do this, and can they really do it alone?
So I want to make sure I'm answering the right question. You want me to kind of reflect on how we're actually managing kind of the well-being writ large of the 13,000 people that we employ, and as part of a community, but also as a major employer in the state. It's interesting. Money's important, and our labor costs have gone up 13%. And of course, our reimbursement hasn't, so everybody is kind of facing that squeeze. But it's not everything. I would say employees, and it doesn't matter if they're a housekeeper or the chairman of medicine at our organization, they want a couple things. They want respect. And I think we pay a lot of lip service to respect in organizations, but you can tell when you walk into an organization if that's a basic value that people are living every day. Second thing is they want autonomy. They don't want to be managed completely by somebody that just says, just do this. They want to have some type of input in terms of the quality, how they do their work. They want to have a little bit of that freedom. And they also want to be developed. They want people that are actually interested in them, in their careers, and will build and support career ladders for them. I actually get emails from all of our employees. I write a journal every single week that goes out to every employee in the health system. Some people don't like it necessarily. People complain that I talk too much about my cats and maybe my personal life, but it allows them to know me. But it also gives them the freedom that they can actually just email me directly, and they do. And I can just tell when our employees are in situations that either really allow them to flourish and soar, and employees that are in work situations that maybe are not the optimal ones. And when we kind of look at how do you get at this, because we have multiple, micro environments where people work, it has to do with not necessarily educating our leaders who are all kind of bought into the fact that it's a lot more than comp. It has to be the environment and the autonomy you allow employees. It's kind of a couple layers down. It's our supervisors that we don't always spend enough time and effort teaching them how to be leaders and how to lift up their employees. I would say that when I came here, I discovered that we, as a cost-cutting measure, eliminated all of our leadership programs for our supervisors. So we had 4 or 5 years where we didn't train any supervisors to actually manage their employees, to create the optimum working environment. So we had a lot of catching up to do. And we started new programs about 2 years ago, trying to educate every single supervisor about what it meant to manage conflict, to support their employees, to create environments of respect. That is something that every single organization needs to do. And it's not just in healthcare. You see high performers across many of the industries in the Upper Valley that are doing a great job and maybe even doing it better than we are. So,
any questions from the audience? Comments?
Yeah. The next question actually.
You have somebody over here.
The next question actually is for Tim. Tim, thank you again for your presentation. You highlighted in your presentation with the creation of the opening of the orthopedic urgent cares, how you're taking the strain off of the emergency rooms. And we know that the emergency rooms are highly taxed right now, a lot of it being because of a workforce shortage. But are there any other delivery improvements too that you're also working on at this time to help with any sort of improved flow and access and maybe other areas that were not highlighted in your presentation?
Yeah, thank you. I think there are three big areas we're working on. One is spine, and I say that as I'm sitting in front of a 2016 spine surgeon graduate. Spine care is a very fragmented market when you think about it. I think everybody in this room has probably had back pain or knows somebody who has back pain, and you think to yourself, oh my gosh, I have a disc herniation. I need to go to the emergency room, or I'm going to need to have surgery. And patients really don't know where to go. They don't know whether to go to the chiropractor. They don't know whether to see a physical therapist or whether they actually need a spine surgeon. So we're working on spine care very similar to what we've done with the walk-in clinic, where there is a navigator who can evaluate somebody and put them into the right clinical pathway. And then that pathway is reviewed over and over again. Are they in the right pathway? Do they need therapy, or do they need to see a spine surgeon or a physiatrist? So spine care is one. The other one is trying to get patients out of the hospital who don't need to be in the hospital. People who have joint replacement surgery, I think most institutions are doing this, people who have joint replacement surgery, but by getting them out of the hospital means that you need to have a home health care program that takes care, a really robust home health care program that takes care of the patient once they go home from the hospital. And that includes spine fusions too. We're trying to get our cervical spine fusions out of the hospital. Most of them don't need to be in the hospital. And then finally, for sports medicine, instead of having the walk-in, can we do this by a video chat where somebody has a ski injury in New Hampshire? Are they able to call us on the video, which would be staffed, and talk to one of our PAs on the video, and then get integrated and coordinated care after that chat?
Great, thank you.
For Joanne, why would someone choose a career in healthcare now?
I actually have lectured to a lot of medical students, high school students, college students that are thinking about a job in healthcare. Regardless of all the crap that people put up with, we have the best jobs in the world. We do. I can't tell you how many times I've stood next to a lawyer. Are there any lawyers in the room? I've stood next to a lawyer who said, I really, I love what you do. It is incredibly fulfilling. I know, as an anesthesiologist, that I made a difference in people's lives every single day, small and large, but I made a difference in their life. Sometimes you would save a life. Sometimes you just allow somebody to be less anxious about a procedure, but you have a measurable impact on people. And people open up their lives, they open up their personal histories and tell you things that they probably haven't told their best friend. And in the most vulnerable time in their life, which is like that 30 seconds before they go under after they've had their Versed and they tell you everything. That's like an incredible privilege to actually be able to do that. And I can't think of a job that's more fulfilling. I get it that there are a lot of people in healthcare that are done with healthcare after the pandemic. They're burned out, they had post-traumatic stress syndrome after kind of what went on in their institution. I totally understand that. But when you actually think about also the privilege and the opportunity that you had to really make a difference, it's immeasurable. It would be interesting to see what people say 10 years after the pandemic. Having lived through like Hurricane Hugo, people mark their life almost related to a specific incident in their life for almost 10 years. And then after 10 years, it just becomes a blur with everything else that's going on in their life. It would be interesting to look back 10 years from now to see how people actually regard how the pandemic changed their life and changed their appreciation for their contributions to their community and to the lives of other people.
We'll just do a few more questions from us as the moderators, and then we're going to definitely open up to the rest of the audience. So this one actually goes to Tim. How would the integration approaches you've developed in orthopedics, are they being replaced or replicated, in other service lines that you're aware of?
They're being replicated in other service lines, but not to this degree. For example, we have a cardiovascular service line, and that's the type of thing which is, I would call, relatively inelastic, right? So you're gonna have a hard time having an urgent care center for just cardiac issues. But we're taking a more of a service line approach throughout the hospital, having more teams, because our urgent care center for orthopedics is more of a team approach with the PA and the physicians and the MAs. So it's more team-based care as well, but not to this extent.
Mm-hmm.
So I have a question that rings true to my heart for Joanne and many people in this room as I see the demographics here. How do you handle generational differences among groups in the workforce, which can create tension? For example, boomers versus the younger employees.
Yeah. There's been a lot of conversation about that. And I know people say, these Gen X people don't really want to work. And you know what? I don't think you can broad brush stereotypes of generations, because when I see these young physicians that are residents and medical students, they're actually working really hard. I don't see a lot of them kind of checking out. They are, ambitious. They know that they, have a great opportunity for a career in healthcare, and they are working incredibly hard. Now, having said that, I would say that, and you don't want to get a bunch of old people talking about, and I was trained, how hard I worked. It reminds us of our, parents that used to say, I walked 5 miles to school every day. So I would say that their desire for work-life balance is palpably different than ours. They are very specific about patient contact hours. They're very specific about call coverage. They talk about it right in their their initial interview for a job. And I would say that there are many things we know we cannot recruit for professionals to go into positions unless you're really specific about that. There was a recent article in the Wall Street Journal about nurses in the gig economy. Did you guys read that? It was really interesting. Like, we've been talking about it up here for a long time. I think it just doesn't advantage young new nurses, though. I think it advantages probably working parents that want to work 4 to 6 hours, in between kids going to school and coming back from school. And we are pretty inflexible in terms of our work shifts. I mean, it's been maddening trying to get our nursing workforce out of this 12-hour shift mentality that you got to work 3 12s. And it's fascinating that they've developed this market where people can jump in and jump out of working shifts. And a lot of people say, well, I don't know if that will work in healthcare. Well, it works in the airline industry. I mean, all of your airlines have flight stewards that bid for trips across the country. And they have a certain level of training, so they have basic competencies and how to board a plane, how to exit the plane, how to deal with disruptive passengers. I mean, they all know how to do that. And so they bid for trips around the country. Could we see something like that in healthcare? I don't know. I think that'd be a great project for somebody to start thinking about. Because I'd love to take advantage of people that want to work up here in the winter or in the fall. That could be a recruitment opportunity for us. But we know they want something different. And we have to be kind of flexible about really accommodating them. I would say those are the big generational differences. I do ride a scooter across the campus. I get incredible crap for doing that. I do wear a helmet. And, but it is, I would say that it's important for us to kind of say we can't paint it in terms of the generation, but just it's much more a healthy balance that I think people are demanding. So.
Tim, in your presentation, you highlighted obviously how the urgent care provides value across the delivery system. Are there also other areas in which you're addressing your workforce within the urgent cares, maybe their specific needs, looking at retention rates, potentially burnout? Is there anything that you would like to highlight in terms of how you're actually measuring a bit of the workforce stressors and keeping track of those?
Yeah, we employ mostly PAs who see patients. And we offer, because it's open, it's now open 8 a.m. to 8 p.m. every day of the year almost. We're able to, especially on the weekends, coverage has been hard. But just as Joanne just said, we're able to bring people in who want to do just a 4-hour shift, and we're able to plug those shifts very easily because we have working moms and other people who want to work, they want to get health care benefits, they want to get retirement benefits, but they can't work a full schedule. So that has worked out actually quite well for us, that we've been able to plug the holes in the schedule.
And I think we have one final question. This is actually for the both of you. And you know, Joanne, you kind of highlighted this a bit in your presentation about technology, but I guess how do you both foresee technology playing a much larger role as we think about responding to some of our workforce challenges?
So I'm a Star Trek fan. I'm sure a lot of you in the room spent a lot of time just talking about how technology could change care. And if you think about it, I do believe we're going to have holograms that will interface with patients. They've been working on avatars with the federal government for a long time. And the technology will get better and better. And you may even be able to, decide what your avatar should look like, your healthcare avatar that you're going to talk to. I think that we are going to use artificial intelligence in a way that we haven't considered it before. Remember, AI got a kind of a bad rap in healthcare because we put it right into the exam room. Remember some very disastrous experiments at MSK and MD Anderson trying to diagnose complex cancers, and they were unsuccessful, amazingly unsuccessful. Then they were on the in the Wall Street Journal and the New York Times. But these new AI programs actually are doing a great job in some basic diagnosis algorithms now. So the technology is getting better and better. I think people say patients won't accept that. And I think we underestimate what patients will accept. They may not initially like it, but they won't be waiting in emergency rooms to interact with a in-person provider, but can use a chatbot and AI on their computer at home in order to kind of think about the differential diagnosis of their symptoms. And this will educate patients a little bit more. It will also, I think, offer us an opportunity to integrate things into the electronic health record that when they actually have to see an in-person provider, a lot of the work may well have been done. I think, too, that we have to think about even our basic, what we consider you have to be in person to clean the floors of the hospital. We have been working with vendors to see if we can get robots to actually clean the floors. If all of you have a Roomba, like who should invent the hospital Roomba that actually goes through the facility 24 hours a day to clean our floors? And why do we actually need an army of environmental service workers doing that? There are all these things that we have got to start considering because, again, the workforce is just not going to all of a sudden magically appear. And we have to think about what's our world like with 20% fewer healthcare workers. So.
a really, really simple innovation that we did is we partnered with a very large joint replacement company and a company that makes computers that has an apple on the front of the computer. And we're using their watch for patients who go home the same day after surgery. And that watch transmits the patient's heart rate, the patient's blood pressure back to us. So we have a navigator who watches those patients who go home. The worst thing about doing a joint replacement, if you remember the people sitting in this room, when you had a joint replacement, patients would come into the hospital 2 days before, and then they would stay a week after. So sending somebody home the same day after a hip replacement or knee replacement with a 500 cc blood loss, you think about that, and the patient, once they get home, the patient feels alone. They feel like, oh my gosh, what do I do now? But by having this simple innovation with just a watch that transmits back to us, our navigator then calls them every day and says, hey, I see on your watch your pulse rate is up. Are you drinking? They don't feel that sense of being alone. We're also able to tell who's going to get into trouble so they don't come back to the emergency room. Very simple innovation, straightforward. It's worked out really well for us.
I think we will now open it to the audience. If you guys have any specific questions, there are 2 mics, one on each side for either Joanne or Tim.
Good morning, Rob Green, class of 14 from MHCDS. Thank you for your presentations and a lot of exciting innovations coming down the line. I'd like to just take a moment though and come back to a little broader picture. I'd want to get people's thoughts and maybe pose this for other points in the symposium about the roles of public health, population health, primary care, behavioral health, substance use disorder treatment and prevention in reducing the pressure on the workforce further downstream. Thanks.
So I'll start. I know I saw Will Torrey here, who's our head of the Department of Psychiatry. This is actually where technology has been really successful. I think still about 80% of our behavioral health visits are virtual still. And it's done a couple things. It's decreased our no-show rate incredibly because people actually make time for their appointments when they actually don't have to go to a physical site, that they can take it from their dorm room, their office room, et cetera. And that's kind of a little bit of a success. I mean, it's actually a big success when you think about considering how we're going to deliver care with fewer people. We've just got to get a little bit better on, all the humans that are involved in actually making that successful. Because we did wrap around a lot of people to make sure that as we launched into telehealth that we actually could connect with patients, et cetera. But we'll get better and better at making that process more and more efficient. I think actually the broad Dartmouth community has been focusing on behavioral health, actually identifying when people text on the phone. I think it might be Lisa Marsh that is working on identifying early depression by just patterns that people use when they text or communicate through email or text. Almost like an early warning system. How do you identify people that need help before they actually get into situations where they have to actually use a higher level of care to address those issues. I would say that rural America is a little bit more challenging because of the internet issues. I don't know if any of you drive by the co-op, but whenever you do, like your phones all of a sudden drop. And you would think, yeah, you've had that happen. And you'd say, well, why is this happening in the middle of Hanover, New Hampshire? But really across rural New Hampshire, Vermont, the actually cell service is incredibly sketchy. And that creates real issues for us actually connecting and reaching out to the community. We have underinvested in public health, for the last 40 years. I don't know if we've ever invested in public health. The pandemic kind of brought that front and center to people, but nobody did anything about it. You know, show me a state where they really invested in public health in anticipation of the need and the importance of public health. I can't identify any state that has. They kind of nodded their heads, but very few states have really invested in this. And New Hampshire has not invested either. And you know, I think that's something that the next public health emergency, you know, we're going to suffer for that. Right now, I would say most people felt that the default was the hospitals and the health systems were providing the public health infrastructure. We set up the lab, so we didn't have to send samples to Atlanta. We backed up the state lab when they were overwhelmed. We do vaccination clinics. We did everything to really support the public health infrastructure. I'm not sure that that's the best way to actually use our resources, but I would say the federal government, the state governments have decided not to address it. So.
Good morning. Thank you as well. I'm Jean-Pierre Nyemazi, and I'm from the class of 2014. I'm pleased to be back here after so many years, and glad to see you all. I'll probably not be contributing to the US system at all on what I'm going to say, but you know, to start with, I'm coming from Rwanda, which is another different setting, different to what you're talking now. But what I could see is that the health workforce issue is really universal. That's something I wanted to note. And actually, it becomes more complex when you go to the low limited resource countries, because in addition to what you've said, you know, the education issues, the retention issues, and all of that, there's also an international migration of healthcare workers. Most of our qualified doctors are now leaving the countries, right? Mm-hmm. So when Tim was talking about Kathleen waiting for 5 hours for an orthopedic issue, back home, 7 months, 12 months with an urgent orthopedic issue happens, and unfortunately becomes common, which is of course not good. But then how do you address that? How do we address that? I think something that Joanne spoke about well is that I think we need to do all of that, retention, education, you know, healthcare coordination and all of that, but we also need to emphasize on the self-care. We need to do proper triage of our patients. So I'll give you an example. You know, our patients back home, when they have an issue, let's say orthopedic issue, they all want to go to the facilities. If we don't have proper triage system at the hospital, you tend to have all of them channeled to one orthopedic surgeon you have in the facility, serving around 400,000 people, for example, and that same personnel will just leave because they can't cope. They'll have a queue of 120 patients a day. You know, what's the type of quality of service that person will give? None. What's the type of life that doctor will live? None. So you need to have a proper, I think, to me, service coordination so that you can triage and see who needs what exactly. Mm-hmm. And you'll find more do not actually need that service. Instead, you're going to make the experience worse because they wait for long. So, Tim, if there's any experience you could share with me in terms of, you know, how do you organize the services so that the people who really come to the office are really the one who need to come, not just you're going to have many who will be joining you in there. So I think that's going to be key, especially for us who are coming from far and who don't even have lots of resources to put in place to educate, retain, and do all of that. So I'd also like to understand from Joanne, in terms of self-care, in terms of educating the communities to really not flock at the hospitals, sometimes managing themselves. You know, what is it working? Like, what did you try to see how the self-care really get more of energy and so that you retain more patients down there instead of flocking to the hospitals? I think that would be interesting. Thank you.
Thank you. I can tell you that from my standpoint, even though we're on pace to see 20,000 patients, half of them did not go on to see an orthopedic surgeon. Half of them were treated by a PA or an NP who's working at the top of their license. And obviously what we're trying to do is make sure the patients who are seeing the surgeons need to see a surgeon. So many of those patients didn't need to follow up with an orthopedic surgeon. They even followed up in clinic with a physician assistant. And that has allowed us to see more and more patients. That's a really good question.
Yeah, I think the topic of self-care is something that Americans are getting better and better at. We have a virtual urgent care, and it is an increasing number of our employees are actually starting to use this rather than actually going to a bricks and mortar urgent care or going to the emergency room. And it can be both therapeutic and educational for them. But the question is, how do you actually set up the interface using technology? That we have said in healthcare for a long time, 85% of what we do is like an algorithm. And it's the 15% that is really difficult and requires a level of kind of being a medical detective to kind of figure it out. But with AI, that probably is actually getting even more narrow. How do you actually integrate that in how we deliver care? I would say, though, that Americans are really interested in self-care. If you think about it, our point of care testing, people want it in their home. I mean, they want to manage their own coags and their own diabetes testing. We've seen an explosion in people actually managing their diabetes themselves. We just got to provide them with the tools and the technology so they can do that. Using wearables and connecting it. In the future, you might not need a person to actually monitor that. You'd have AI, and you'd have somebody that sounds like a person calling individuals and saying, your heart rate's up. Are you drinking enough water? And these are the things that we're going to have to develop when we actually don't have people to provide those services. So,
I think we have time for one more question, and then we're going to go to break.
Great. My name is Meredith Milligan. I am a MPH student at the Dartmouth Institute, and I'm also a family physician. And so I'm coming at this from the primary care standpoint. And I really applaud all the innovative ways to improve care access that you've talked about today. But whenever I hear about alternative ways to deliver care, I find myself also wondering about the risks of healthcare fragmentation. And so I'm wondering how you balance, or how you think about balancing, improving healthcare access with providing care that's whole person centered and is really integrating specialists with primary care clinicians where they're available, of course.
Do you want to start?
well, I have a 99-year-old mom, almost 99, who lives at home with me, and after a stroke 3 years ago. And I have to say that we have been able to actually integrate accessing expertise when we really need it instead of overutilizing. Let me give you an example. Our geriatrics team at Dartmouth Hitchcock is pretty impressive. They have about 400 patients that they care for at home who are homebound. They have a 24-hour number that you can call and get a provider and answer a question. And you would say, oh my God, they must have their phone ringing off the hook all the time. I'm not sure they do, because they really have, they spend a lot of time educating caregivers about how to care for people at home. And I would say we've used that number probably 3 times in the last 3 years, and didn't require anybody to come to the house, but allowed really the expertise to kind of come into our home. We've done virtual visits on wound care. We've done, used a lot of technology that probably is a much more efficient use of their time. I think one of our challenges are that we're talking all of this in the world of a fee-for-service visit. And the thing is, a lot of times people need a 2-minute answer on a phone, or they need a text message, or they need something that's not a documented 30-minute visit that you can bill a mid-level office visit code for. And the only way we're going to get to that point where we're delivering care how and where people need is actually when we're probably in a total cost of care payment methodology, where you figure out what people need. And it's interesting, again, my mom is going to be 99 in June, and I called her physician, who's wonderful, Stuart Lewis, and I said, listen, Stuart, she's sleeping a lot, and I said, is this what the end of life looks like? He goes, no, that's what a UTI looks like. He goes, let's get a clean catch urine. And she had a Klebsiella UTI. So there are times that's actually, it was a text. And yet, we kind of activated both the diagnostics and the intervention in probably a less time-intensive way. And the thing is, our payment models probably get in the way of us delivering a lot of our care in a much more efficient way. So, I would say the AHA is already saying, our future is in total cost of care. We just got to figure out what it looks like to actually get there. And it may be different for different regions of the country and different entities within the healthcare system, but that's probably where we can most efficiently utilize the resources we have. So.
And to be specific about us, the primary care doctors refer their patients to us. And for the most part, the primary care doctors are happy to have that patient, for lack of a better phrase, taken off their plate. So if you look at Caitlin's story, how many messages via Patient Gateway? Patient Gateway is our access, our portal for patients. How many messages would have gone to Patient Gateway to the primary care doctor regarding Caitlin versus that being taken off their plate and their staff's plate as well? And we saying we're going to accept that and we're going to communicate back to the primary care doctor about what's happening. So it's not to remove the primary care doctor from the equation, it's to work as a team. Thank you. That's a great question.
Well, thanks to you guys. We're very happy to have all, and we're happy to have all of you guys.